Hello, my name is Lisa Matizak, and I am the PATH for PWS Study Coordinator. With me today to talk more in depth about the issue of hypogonadism in PWS is Dr. Diane Stafford. Dr. Stafford is a clinical professor in pediatrics in the Division of Endocrinology and Diabetes at Stanford University in California. She has been providing care to children and young adults with PWS for over 20 years and has a particular interest in disorders of puberty common in those with PWS. Thank you, Dr. Stafford, for joining me again today to talk with us in more detail about the challenges associated with hypogonadism in the PWS population. When we last spoke, we covered the basics of hypogonadism, what it is, how common it is in the PWS population, as well as treatment options. The information you provided was incredibly helpful to our community, and I'm thankful for the opportunity to speak with you again. Today, I want to take a deeper dive into what is happening in the body when a person has hypogonadism, testing that should be done, and the risks and benefits of sex steroids. So let's begin. My first question is, why does a person with PWS experience hypogonadism, and what is happening in their body that is different?
Hypogonadism in PWS is felt to be due to some of the same hypothalamic dysfunction that causes growth hormone deficiency, hyperphagia, other things that are common in PWS. We spoke the last time about what we refer to as the hypothalamic pituitary gonadal axis, and I think we have another diagram of that for people to look at. The hypothalamus generates a signal that then is transmitted to the pituitary, that causes the pituitary to make other hormones that then affect the production, that cause the production of estrogen and testosterone at the ovary or the testis. Defects anywhere along that pathway can be a cause of hypogonadism. While initially it was felt that the difficulties in PWS were largely caused by hypothalamic dysfunction, it seems to be more complicated than that. And there appears to be some level of dysfunction both at the hypothalamus, but also potentially at the ovary and the testes as well, which has actually made it quite difficult to investigate the true etiology of the true cause of hypogonadism in PWS. But essentially, what is happening is that the signal is either not being sent or not being received. And therefore, there's a lack of production of testosterone and estrogen by the ovary or the testis, depending on whether you're talking about boys or girls. Studies have really been looking at the causes of these variations, but not terribly successfully in isolating one prime cause, as is true in many things with PWS. So it's now felt to probably be a combination of things, of both hypothalamic dysfunction and gonadal dysfunction.
Interesting. So sometimes younger children and teenagers have body odor and are growing hair in new places on their body. So does this mean that they're going through puberty?
So I'm really glad that this is a question that we're having a chance to talk about, because it's a topic that I think even a lot of pediatricians find very confusing, and that is the distinction between what is truly puberty and what we would term adrenarchy. So we talked in the last segment that the beginning of puberty in girls is the beginning of breast development, and that in boys it's an increase in the size of the testes. That is true puberty, and that is driven by this hypothalamic pituitary gonadal axis that we've been talking about. The development of body hair and body odor is actually controlled by a separate system, or the hypothalamic pituitary adrenal axis, that causes production of what we think of as male hormones or androgens by the adrenal gland, and causes body hair and body odor. The term we use in endocrinology for the development of body hair and body odor is pubarchy, which is usually caused by adrenarchy, or activation of the adrenal gland, which sits above the kidney, to produce these androgens, or these male hormones, usually beginning about 6 or 8 years of age is typical. The problem that people encounter is that typically we don't actually see body hair and body odor until around the same age that we see the beginning of puberty. And so the two are associated in our minds as happening together, but because they're controlled separately, they can actually happen at different points in time. So what we see in PWS is a very high rate of what we term premature adrenarchy, which is either an increase in activity or an increase in sensitivity to the normal activation of the adrenal gland. And we actually see it in, so one study has said about 30% of girls, about 16% of boys. Actually, some recent yet to be published data from my own experience is probably closer to 60% in girls. And about 35% in boys. We don't really understand why it's more common in girls than it is in boys, but it certainly is, both in the PWS community and actually in more typically developing children. And so understanding that distinction, I think, can sometimes be helpful for parents in understanding whether or not this is puberty or whether this is adrenarchy, for all the reasons we talked about last time, that understanding the timing of whether or not somebody is heading into puberty is an important aspect. So it's frequently true that people will say, oh, well, she has body hair and body odor, so she must be in puberty, so I don't need to worry about hypogonadism, when in fact, the fact that these two portions of what we think of as puberty are actually separate.
That makes sense. So during our last conversation, you mentioned treatment options for hypogonadism can be estrogen for females and testosterone for males. How can use of these sex steroids help a person with Prader-Willi syndrome?
So it depends a little bit on when you're starting. In younger children who are at the typical age of puberty but not progressing into puberty, the use of sex steroids actually, it certainly causes all the body changes that we associate with puberty, but more importantly is actually really important for longitudinal growth, for growth in height. Growth hormone certainly increases the growth in children with PWS, but but estrogen and testosterone actually increase the body's own production of growth hormone, and therefore result in that increase in growth rate that we see at puberty. But there are also some direct effects of estrogen and testosterone on long bone growth. And so just giving growth hormone, but without the addition of testosterone or estrogen, doesn't usually give somebody an adequate growth spurt that you would typically see through puberty. And so if we add testosterone and estrogen at the right point in time, we can increase the rate at which somebody's growing, and therefore also increase their adult height. The other aspect that I think we lose track of because it's not something we can see are the effects of estrogen and testosterone on bone density, on the strength of bone. Girls and boys typically pack away bone into their bone bank, is the usual term that people use, between about 12 and 25 years of age, and that is largely due to the effects of estrogen or testosterone. And without those, you decrease the amount of bone that you're actually storing away and increase your risk for osteoporosis, osteopenia later in life. The reason that's particularly important in PWS is that we know that children with PWS are at risk for lower bone density because of their lower muscle mass, and because they tend to not engage in weight-bearing activities, in sort of strenuous weight-bearing activities as much as typically developing children because of their muscular weakness. So both of those things put them at risk for development of osteoporosis later. And when you add in the potential for lack of sex steroids, you may not change anything right this minute, but you are changing an outcome in the longer term for them in terms of their bone density.
Makes a lot of sense. So what testing should be done to determine if my loved one needs these medications, and how often should the testing be done?
Yeah, so the first thing to do is observation. as we talked about before, is looking for signs of puberty. Are they happening at the right time? Are they not happening? So signs of puberty or lack of signs of puberty in girls starting around 10 years of age, in boys starting around 12 years of age. The other thing to watch out for is, around the same time is a decline in growth velocity and growth rate. That may signal that the body is ready to see these hormones in order to be able to grow at a normal pace. So those are the things you can see even without testing. The next thing to do is actually to look at blood tests related to LH and FSH, luteinizing hormone and follicular stimulating hormone, which are the hormones that are produced by the pituitary in response to the activity of the hypothalamus, and see whether those are starting to rise as you would expect through puberty. And then looking at estrogen and testosterone levels, depending on whether you're talking about a boy or a girl, to see whether those are also rising as well. There is some difficulty in interpreting these in PWS on occasion for the reasons I was talking about sort of this mix of hypothalamic dysfunction and gonadal dysfunction that you can sometimes see. They look like they're starting to rise. And so you think, okay, this person is heading into puberty and all is well. But then if you look 6 months later, either at their physical exam or their growth or these levels, they're not changing in the way you would expect over time. So I tend to look more closely around that period of normal puberty to figure out whether somebody is heading into puberty at the time that I would expect. Later on, for young adults who've entered puberty on their own and progressed, looking at testosterone in LH, FSH, and testosterone in young men, in young women, starting with just a menstrual history, finding out whether they're actually having normal periods. And then again, if they aren't, looking at some of these hormones again to figure out whether or not they actually have a deficiency that might require treatment.
So that brings up an interesting topic, which I see a lot of talk about, is that some families worry about the side effects from taking a sex steroid. So what are the possible side effects and how common are they?
I think it's important to remember that what we're doing is giving back what the body is not making on its own. And so if we do that in a measured and an even manner, we should not be seeing ill effects from testosterone therapy or estrogen therapy in terms of behavior, in terms of other changes in, people worry about changes in cholesterol and things like that. There are actually benefits of testosterone and estrogen in terms of lipid metabolism, in terms of cholesterol and those kinds of things. There are concerns about, the biggest concern I hear about is change. Mm-hmm. And I think it is easy to perceive behavioral change when you start giving somebody testosterone. It's a very high placebo effect of testosterone, that people really do start to monitor children and young adults much more closely, and maybe see changes that may or may not be related to testosterone therapy. I think being aware of them, talking about them, going up on dosing slowly so that we can make sure that people are comfortable with that progression is really important. But I don't see a lot of effects that some people would worry about in terms of changes in liver function or kidney function or things like that with testosterone. And I think because we're doing it in a measured manner, and because we're essentially trying to get testosterone levels to where they should be for age, rather than giving somebody huge amounts of testosterone. Similarly with estrogen, when you start estrogen therapy, you will see body change. You will see more breast development. You will eventually get to the point of having bleeding, of having menstrual periods, which is a big concern for families in terms of being able to manage menses, particularly given the variation of cognitive levels within PWS and ability for to manage skills of daily living within the PWS community. It's important to understand that management of menses is something that we can accomplish without having to say we're not going to give somebody estrogen at all. That discussions about whether you give estrogen and progesterone continuously, whether you have one period a year, whether, there are lots of different ways to manage that. And having those conversations with your physician about what is in the best interest of your child is really important. And I don't think in either the case of testosterone or estrogen, that has to be not giving them back what their body would normally be making.
So what is the downside of choosing not to use the sex steroids?
I think that gets to some of the conversation that we've been having about sort of general health and the effects of testosterone and estrogen on general health. They're very important. So if you don't have a growth spurt, you will be shorter than you would be otherwise in terms of that longitudinal growth that we see during adolescence, during puberty. Decreases in bone density are definitely associated with lack of estrogen or testosterone. For children who, for a lot of children in my experience, having a body type, a body habitus that is similar to their peers is actually quite important to them. That particularly for girls where it's a little more obvious, when everybody else is starting to develop breasts and wear bras and all of those things and you are not, that can actually be psychosocially very difficult for some of these girls. Similarly, the boys aren't quite as, don't seem to be quite as attuned to those kinds of things, but the inability to develop appropriate muscle mass, exercise tolerance, all of these things are linked to estrogen and testosterone and having the appropriate hormonal environment through adolescence and later in life. So again, I think it's important to think about this not as medication, but as giving back what the body would normally be making if the defects in this particular axis were not there.
Makes sense. So if my child was to begin taking a sex steroid, would I expect that they would need to take them for the rest of their lives?
It is likely that if you don't go through puberty on your own and you need to and you need sex steroid replacement in order to initiate puberty, that you will likely stay on. I have had some girls and boys where we've stopped temporarily to see if their own system would take over after they've finished growing and after we've sort of gotten through that particular phase. In general, I think the assumption is that the assumption should be that you're going to need them for ongoing maintenance of your own testosterone and estrogen levels. I will say that the one caveat to that, and in looking actually at the global database, the data in the global database about testosterone and estrogen replacement therapy, there is a group of boys who are given testosterone very early in life with the intent of trying to see if their testes, which may not have descended, will descend with the effects of testosterone. That is a much shorter course. And that certainly does not mean, having needed that or having responded to that does not necessarily mean that you will have hypogonadism later, although it should be a clue that that's more likely than not. Under those circumstances. So that's the one aspect of sometimes there's treatment very early on. That doesn't mean you're going to need lifelong treatment later on. But certainly in the adolescent period and going forward, once you have been diagnosed with hypogonadism in PWS, that is likely to be a lifelong problem.
Dr. Stafford, I want to thank you again for this insightful talk on hypogonadism in PWS. Parents of individuals with PWS benefit greatly when armed with the knowledge of the common issues in PWS such as this. It is imperative that we know what signs to look for and what questions to ask our respective endocrinologists. And this conversation has me feeling better prepared to watch for signs of hypogonadism in my son and to ask the questions that will ensure that he receives the best possible care. So I want to thank you again for imparting your knowledge and giving so generously to the PWS community. Parents, if you would like to help us learn more about hypogonadism in PWS, I would encourage you to visit the Global PWS Registry at www.pwsregistry.org and complete the endocrinological history survey so the experiences of your loved one with PWS is represented. For questions or help with the registry, please email info@pathforpws.com or call 760-420-5878. Thank you.